I think we'll go ahead and get started. We should have interpretation in both English. Sorry, all of the presenters will be speaking in English, and we will have hopefully French and Portuguese translation. We're still waiting for our French interpreter to join the call, but we're hopeful that that will happen in a moment. So welcome this morning to our webinar, Optimizing the Use of Antimalarial Medicines During the First Trimester of Pregnancy. We'll be going over the updates and next steps with regard to the policy. For a little bit of background, I'm sure you're all aware, but malaria infection in pregnancy is a massive public health problem, with 13.3 million pregnant women infected with malaria in sub-Saharan Africa alone last year. Safe and effective antimalarial choices suitable for use by individuals who are pregnant or breastfeeding will help us deliver on the global malaria elimination and gender equity goals and the Sustainable Development Agenda by 2030. WHO's recent recommendation of artemether-lumefantrine, which we'll be hearing about today, as the preferred treatment option against uncomplicated malaria in the first trimester of pregnancy, is a very welcome development, as it will allow for more effective treatment of malaria infection in this population. So to open us today, we will be hearing from Dr. Andrea Bozeman from WHO talking about the policy. Then we have a presentation from Dr. Stephanie Delacour to discuss the science and the data behind the policy change recommendation. Next, we'll hear from Dr. Helen Varsosio around work on a pregnancy registry to collect additional data on safety of antimalarials in pregnancy. And finally, we will hear from Dr. Abdallah Lusasi from Tanzania to discuss changes to the policy in Tanzania. So Amanda, can you go to the next slide, please? So just as a reminder, once our French interpreter joins, you should be able to choose French interpretation.
Sorry to interrupt, but I think she joined and you need to assign her to the channel.
Great. Okay, so we have our French interpreter now. So in your meeting and webinar controls on the bottom of your screen, you should have this button that says interpretation. Click on the button and select your language of choice. And then you also need to click to mute the original audio. And we would like to encourage everyone to put any questions into the Q&A section and not into the chat section. And next slide, please. And similarly, in Portuguese, in your meeting controls, you click the same button, select Portuguese, and then mute the original audio. And again, we encourage you to use the Q&A for questions. Next slide, please. So I'm very pleased to welcome Dr. Andrea Bozeman, who has worked on malaria control since 1984 and has been at WHO since 1993. He started his career in WHO in the malaria unit in control of tropical diseases and worked on community-based malaria control in Tigray, Ethiopia, the malaria component of the Integrated Management of Childhood Illness, IMCI, and the WHO protocol to assess therapeutic efficacy of antimalarial medicines. He has lectured on malaria epidemiology and case management in over 25 WHO international training courses, mainly in Africa. He most recently supported the project for rapid expansion, or RACE, of integrated community case management of malaria, pneumonia, diarrhea, and malnutrition in children, which was implemented in 5 high-burden African countries. And currently, he is the acting interim director of the WHO Global Malaria Program. We are very thrilled that he is able to join us today. So I will hand it over to Dr. Bozeman. Thank you.
Thank you very much, and good morning, good afternoon, good evening to all of you. If I can have the next slide, please. I will be introducing now the new recommendations. If I can have the next slide. has been released in November 2022, and is part of this new consolidated WHO guidelines. In the past, we used to have different guidelines for treatment or for vector control, elimination, and surveillance. Now they are all in one single document, which is updated regularly. For instance, last year we had 4 updates, and we normally compile a set of recommendations, could be on chemoprevention, could be on vector control, vaccine, or the last one were really on malaria treatment. So the next slide, just to be clear on some of the terms, we use a recommendation when we address a set of action that should or should not be done, could be to the individual patient or a clinician or a policymaker. And these are always based on a systematic review of evidence. When we compile a set of recommendations, this come into a guideline development, is the one that I just presented to you as a consolidated guideline. And when it comes to policy, sometimes these terms we confuse with each other. The policies are really the decisions, the plans, and the actions undertaken by the national health authorities, which can take into account the WHO recommendations, but then they become national policies. Then we have a more generic term, which we call guidance, to include many other types of documents, which could be field implementation manuals, or even sometimes information notes if it's more short, but these are really not based on a systematic review of the evidence. For instance, we will have a field implementation manual on community IPTP. So the next slide just describe the process. We follow when developing new sets of recommendation process, which is described in this handbook, is available on the web. And always the guidelines development is considered the top type of WHO normative work. So, and it's very important, and clearly the guidelines for malaria are, for our department and for the whole of the WHO, one of the most downloaded and consulted documents. If you go to the next, I will briefly describe the process. It starts with a WHO-wide group, we call it steering group, which looks at which new recommendations needs to be considered, because there is a country need or the evidence has been evolving over time. And this steering group then recommends to establish a guideline development group, which is a group of experts. These are experts which have not a conflict of interest with the subject. They are independent. And their first job is really to define some specific questions that needs to be looked at through an evidence review. This is the initial phase. We have an internal system in WHO to control that everything is done in good order. We call it the Guideline Review Committee, this box at the top. And then once we call it PICO questions, the specific issues to be addressed are defined, then they are given to an external group of an academia, which will do a systematic review of the evidence. This is the work that Dr. Stephanie Delicourt will be presenting after my presentation. Then the evidence is graded, is summarized in specific ways, is assessed, and then the all work of evidence review and assessment is presented again to the guideline development group, which on the basis of this formulates specific recommendations. This is so at this time, then the final wording is agreed, the text is compiled, and is generally then sent to an external review group, which just looks at clarity. And the text needs to be very well clear and self-explanatory. Finally, this is reviewed by another guideline review committee, is the final step, internal, let's say, quality control system, and then it's ready for dissemination. So this whole principle is really to have the same question, the same topic, to be looked at by different groups, not overlapping between each others, and so that at the end, the conclusions are robust and presented in the most clear possible way. Next slide. Just to give an example on these key questions that are being focused, they really need to, we call them PICO questions. They need to define the population. And in case of treatment of malaria in the first trimester of pregnancy, clearly these are pregnant women in their first trimester. The intervention, so what is being assessed, will be in this case any of the ACTs used and currently recommended by WHO. The comparator will be quinine, which was the previous recommended option for treatment of malaria in the first trimester. And then the outcome are considered critical outcomes in terms of efficacy and safety. And often for especially the first trimester, it will be some presence of stillbirth, miscarriage, or congenital malformation. These are very important. And of course, there are also other elements of tolerability and safety which are looked at. These together with then the efficacy parameters. So the next slide. This is, I explained briefly the different groups. We get to this PICO question, and then the evidence is looked very carefully by these systematic review groups. And once this is retrieved, the evidence is clearly the key building block for the decisions. But there are other elements at the same time. For instance, the experts, they have an decision to evidence, an evidence to decision table, which looks at benefits and harms, looks at equity, feasibility, acceptability, the aspects also about human rights, cost effectiveness, and other consideration by the society. So it's not just the evidence, but other elements are also considered, and they're made explicit in the decision process. At the end result, the recommendations need to be relevant, clearly, and user-friendly and easy to then apply. We expect all countries to be able to certainly adapt the recommendation to their national context and then adopt them in their national treatment policy. So the next slide. Just on some of the terms, you will see that WHO recommendation often they have high certainty of evidence or low or very low certainty of evidence. And this is really based on the assessment of the evidence. For instance, a high certainty recommendation, or in the past we call it also high quality, but more correct is high certainty of evidence, when more research is very unlikely to change the confidence in the estimate of the effect. And then very low certainty of evidence when, on the contrary, is expected that this recommendation may evolve, may change in the future as more evidence will become available. Also, next slide, you will see that we also have these definitions. Some recommendations are called strong, others are called conditional recommendations. So what is a strong recommendations? Let's say for clinicians, a strong recommendation means that most clinicians should actually follow this intervention, and even a compliance or not can be even looked as a performance indicator for quality of care, for instance. Or if it's a conditional recommendations for clinicians, then there could be really different choices could be appropriate for individual patients. And so maybe there should be specific then elements in the decision-making process. Now, if we look at policymakers, a strong recommendation means that the recommendation can be adopted as recommended by WHO in most situations, while a conditional recommendation then will implies that in very in-depth discussion will be needed in country by the technical working groups which are advising the malaria program and the Ministry of Health before adopting those recommendations. So next slide, and we can even click to the next one just to come then to what is new, what is the new recommendation. And this you have probably already written and read all of you. To treat pregnant women with uncomplicated falciparum malaria with artemether lumefantrine in the first trimester is a strong recommendation based on low certainty of evidence. This is the new recommendation. And if we go now into the text, which is just below, let me try to simplify. It's because also you were interested in the questions about what about the other ACTs. Now, the other ACTs, we have two groups. We have those which are in large use, artesunate amodiaquine, artesunate mefloquine, and DHA piperaquine. This should be used in the first trimester, in spite there is more limited evidence compared to artemether lumefantrine, in case artemether lumefantrine is not available or is not recommended, because there is clear evidence that quinine treatment compared to ACT is less effective, and there is major challenges with the adherence to the 7 days, 3 times a day regimen with quinine, plus minus clindamycin, but it's a very difficult regimen to comply. Then we have two other ACTs. One is artesunate sulfadoxine pyrimethamine. Very few countries still use these ACTs. Probably it's been phased out. I think it's only India at the moment. And this ACTs, sulfadoxine pyrimethamine, should not be used in the first trimester because it has been shown to induce congenital malformation, neural tube defects. And so is not recommended. And as we know, it's not also used for IPTP in the first trimester. The other ACT is currently not recommended is artesunate pyronaridine, and this because there is not any single report of use of these ACTs in the first trimester. So one, artesunate SP, because we know it is teratogenic in newborns. The second one, artesunate pyronaridine, because we have really no information. And then we have a clear, strong recommendation to increase pharmacovigilance so that the number of inadvertent exposures, especially for other ACTs, become well recorded, documented the birth outcomes, and then can increase the confidence of safety on the use of this drug. So I hope this explains the current WHO policy. Just next slide, I will briefly mention where you can find more. Clearly, we have documents on our website. If you download, the whole PDF is quite long. It's over 400 pages, but includes certainly all of these new recommendations and much more. We also have a Magic App application, which has been first introduced in WHO with the COVID clinical guidelines. Also relatively easier to navigate between the different sections on the recommendations and the evidence base, which is linked to that. And then we have a malaria toolkit app, which you can download, freely available, which include also the World Malaria Report and the treatment guidelines. If you have it already on your mobile phone, it's better to basically offload the application and reload, because in this way you will get the new recommendation on load. And just last information, we are working on a document with Judith Reth, Stephanie Wellicourt, Rachel Gonzalez, and Bob Clark to also produce a document which in a plain way, describes all the evidence of studies done in pregnancy, both with ACTs, the artemisinin components, as well as the companion drugs, both the animal toxicity data and the human safety reviews. So this is all, and thank you for your attention.
Thank you. Thank you very much, Dr. Bosman, for these updates. This is really setting the ground for the other presentation we have today. So dear participants, remember, don't hesitate to write your question in the Q&A box. Our presenter will take time to respond to them at the end of all the presentations. Thank you. So our next presenter is Dr. Stephanie Delicourt, who is going to present the results of a meta-analysis study on pregnancy outcome after first trimester treatment with artemisinin derivatives versus non-artemisinin antimalarials, which play a key role for the adoption of this new recommendation on malaria in pregnancy. Stephanie Delacour is a pharmacoepidemiologist and principal research associate from the Liverpool School of Tropical Medicine in the UK. She has over 15 years of experience working on safety of antimalarials in pregnancy. She is the co-chief investigator of the MIMBA Pregnancy Registry study founded by MMV, and led the IPD meta-analysis, which supported the change in WHO treatment guidelines for malaria in the first trimester. Dr. Delicourt, we are very delighted to have you with us today. Over to you. Thank you.
Thank you very much. I hope you can all see my screen.
Yes, we can see your screen.
Great, thank you. So I will present the very high-level overview of the results of the meta-analysis that we shared with the guideline development group last year in April, supporting the change in the WHO treatment guideline. And this is looking at first trimester treatment with artemisinin derivative versus non-artemisinin containing antimalarial and the risk of adverse pregnancy outcome. And I'm presenting on behalf of all the co-authors listed on this slide. So as most of you will know, WHO recommended the use of artemisinin combination therapy for the treatment of malaria in 2000. There's been several reviews of the safety of artemisinin in pregnancy because animal studies have shown that artemisinin as a class had some embryotoxic effect in different animal species. During those reviews in 2002, 2006, there was insufficient human data to recommend the use of artemisinin in the first trimester, although since 2006, artemisinin combination therapies have been recommended for the treatment in second and third trimester of pregnancy. In 2015, we presented a meta-analysis to the WHO, and at the time, they recommended the Malaria Policy Advisory Committee recommended including ACTs as an option for the first trimester, but that was not adopted by WHO. And in April last year, we presented an update to this meta-analysis, which resulted, as you've seen from the previous presentation, in an update in a treatment guideline published in November last year. So before I go into the results, it's important to put things into context and assess the profile of the ACTs artemisinin combination therapies compared to quinine, as ACTs have several advantages over quinine. They have a shorter treatment course, 3 versus a complex 7-day regimens for quinine. They're better tolerated. They have longer post-treatment prophylaxis. And they also have some gametocidal property, which may result in onwards reduction of malaria transmission. Although there's no data on their efficacy in the first trimester, data from non-pregnant population and population in the second and third trimester of pregnancy showed that they have a better efficacy. And this is shown here at the bottom of the slide from a review published in 2020, which shows that second and third trimester pregnancy treated with quinine had a 6-fold higher risk of treatment failure compared to artemether-lumefantrine. That review also looked at tolerability, and overall quinine had worse tolerability compared to all the other ACTs. And this is most striking for tinnitus, where quinine had 700-fold higher odds of tinnitus or ringing in the ear compared to AL. And this is important to consider when looking at the benefit risk of different antimalarial treatment in the first trimester. So the meta-analysis aimed to compare the risk of adverse pregnancy outcome between artemisinin-based treatment, and that includes ACTs, but also monotherapies and other combinations such as artesunate clindamycin, and non-artemisinin treatment considered safe in the first trimester, and looking at exposure in the first trimester in the suggested artemisinin embryo-sensitive period. So we did an updated systematic review from the review we published in 2017 and included individual patient data. And this is important to ensure robust analysis using standardized definition and standardized analytical technique. Studies were eligible if they had a confirmed artemisinin exposure in the first trimester. They were prospective, which means that they were enrolling pregnant women before the outcome was known to minimize bias. And they had internal comparison. So a woman treated with non-artemisinin antimalarials or unexposed, women unexposed to antimalarial during the first trimester. Antimalarial exposure definition in the first trimester was any exposure occurring between 2 to 13 weeks gestation. And for the suggested artemisinin embryo-sensitive periods, that's between 6 and 12 weeks gestation. And this is based on the targets for the suggested target for artemisinin embryo toxicity, which are the primitive erythroblasts, which are the predominant red blood cell in circulation in human between about 6 and 12 weeks gestation. And then exposure were considered confirmed if they were documented in more than 2 data sources or in a medical record. The primary outcome of interest was a composite of pregnancy loss, so that's miscarriage and stillbirth, and major congenital anomalies. And this is based on the signal observed in animal studies. And a composite is a more efficient way to look at this important outcome, which are also competing events. I'm not going to go into detail of the statistical analysis, but just to highlight that the primary analysis was to look at all artemisinin treatment together and compare them to non-artemisinin-based treatments. We had pre-specified subgroup analysis, looking at specific ACTs compared to oral quinine. We did a one-stage individual patient data meta-analysis, adjusting for clustering by study sites. The analytical model adjusted for the fact that not all pregnancies were enrolled at the same gestational age, for loss to follow-up, and for the time-varying nature of exposure. We also did a series of sensitivity analysis to assess the robustness of the main analytical model. I will now share the results. You probably can't see from the small print in this graph, but this shows the number of studies that were identified for the systematic literature review, the number that were screened, and finally, the number of eligible studies. So we identified 7 eligible studies, including 12 cohorts that had well-documented first trimester artemisinin data. Most of these 12 cohorts were in Africa, and there was one large cohort from Asia, from a site on the Thai-Burmese border. Overall, there were over 34,000 pregnancies, and out of these, 5% had a confirmed antimalarial treatment in the first trimester. There was 737 artemisinin-based treatments, and out of those, about 70% were artemether lumefantrine. So the vast majority of those treatments were for AL. There was over 1,000 treatment with non-artemisinin based treatment, and the vast majority, 85%, were quinine treatments. This is the result of the primary model comparing artemisinin treatment versus non-artemisinin treatments. We show here the risk estimate for the primary composite outcome and its component, which are miscarriage, stillbirth, and major congenital anomaly. And fetal loss is a combination of miscarriage and stillbirth. The results are presented for the first trimester as a whole, and also for the suggested embryo-sensitive period. We can see here the adjusted hazard ratio, which are also presented in the forest plot. And any effect estimates that are towards the left are in favor of artemisinin-based treatments, and on the other side are in favor of the non-artemisinin-based treatment. We can see overall with the overlapping confidence interval that there was no difference in the risk of the primary composite endpoint between women treated with an artemisinin treatment and those treated with a non-artemisinin-based treatment. And that was true also for the component of this composite endpoint for the first trimester and the embryo-sensitive period. This slide showed the result for the subgroup analysis comparing artemether-lumefantrine versus oral quinine. It's presenting exactly in the same way with the different outcome of interest and the adjusted hazard ratio. And we can see that the effect estimates are all in favor of AL for the primary, specifically for the primary composite endpoint and for fetal loss. The data suggests that women treated with AL had a 42%, if you look at the adjusted hazard ratio, 42% lower risk of adverse pregnancy outcome compared to the women treated with oral quinine. You can see also that there was no major congenital anomalies detected in the 524 women treated with AL in the first trimester. These slides show the major congenital anomalies by subgroup and by exposure group. I'm not going to go into detail. I just want to highlight that overall the number were quite small, and the cases of major congenital anomalies in the artemisinin-based treatment group were cleft lip and palate, a case of bilateral syndactyly, and a case of imperforated anus. And these were none of the signal identified in the animal models. Should be noted that there was a few congenital heart defects detected in these studies. However, none were systematically screening for congenital heart defects, which often requires longer follow-up of infant and might not have been detected by the cohort included in the meta-analysis. So in conclusion, our meta-analysis showed that there was no difference in the risk of stillbirth, miscarriage, or congenital anomalies in confirmed artemisinin-based treatment versus non-artemisinin containing antimalarial that are considered safe in the first trimester. Looking at the upper limit of the 95 confidence interval of the hazard ratio, we can see that the data support an exclusion of a 1.03-fold increase in risk of adverse pregnancy outcome for artemisinin in the first trimester. And for the embryo-sensitive period, we can exclude the 1.45-fold increase in risk, which is very reassuring. Specifically, the subgroup analysis for the only ACT for which there was enough data to assess separately showed that for AL, there was a 42% lower risk of adverse outcome compared to quinine. This indicates a positive benefit risk profile for AL versus quinine for the treatment of uncomplicated malaria in the first trimester, based on the evidence of safety from this meta-analysis, as well as evidence from other population, and namely second and third trimester pregnancy, on efficacy, tolerability, and adherence. As highlighted by Dr. Bosman in the previous presentation, monitoring the safety of antimalarial in pregnancy is very important and should continue to provide further reassurance, in particular to gather more data on ACTs other than AL, as well as to detect specific rarer congenital anomalies. So I would like to acknowledge all the study participants, the contributor, and the funder for this meta-analysis. And if you're interested in more details, the paper is published with more information on all the subgroup analysis and sensitivity analysis that we have done. Thank you very much.
Thank you so much, Stephanie. That was a fantastic presentation. So now we will go on to our next speaker, who is Dr. Helen Barsosio. Dr. Barsosio received her MBBS from the University of Nairobi. She holds an MSc from the London School of Tropical Medicine and Hygiene in Reproductive and Sexual Health, and an MSc in International Health and Tropical Medicine from the University of Oxford. She is currently based at the Kenya Medical Research Institute, Center for Global Health Research in Kisumu, Kenya, where she supports various malaria and pregnancy studies as a co-principal investigator within the KEMRI CDC LSTM collaboration. In addition, she provides technical guidance to the NMCP in a number of areas, including maternal and newborn health, the prevention of mother-to-child transmission, HIV care and treatment, and malaria in pregnancy. If that doesn't keep her busy enough, she's also completing her final year of PhD studies at the Liverpool School of Tropical Medicine in the UK, supervised by Professor Faiko Turkile. It's my great pleasure to welcome her today to discuss the work that she's doing on the MEMBA project. Thank you, Helen.
Thank you very much, Julie. So I'll be sharing work from the antimalarial pregnancy exposure registry, or the MEMBA registry we've been doing in Kenya, and picking up from where Stephanie left off. That targeted surveillance is important to continue so that we can generate evidence that will be reassuring to policymakers as well as providers and patients. And this is where the MEMBA registry comes in. And MEMBA stands for Malaria in Mothers and Babies, which also means pregnancy in Kiswahili, the Kenyan national language. So it was a happy coincidence in names. And as I present this work, I do so on behalf of a very large team of collaborators. The next slide will show you that this work is co-led by LSTM and MMV in collaboration with Warren University of Oxford, who provide data support with implementing sites in Kenya, which is led by Dr. Simon Kariuki, and IRSS in Burkina Faso, led by Professor Halidou Tinto. We are also supported by a birth defects expert committee who review the congenital anomalies, and they have expertise from a clinical geneticist and this morphologist as well. On to the third slide. I can see the slides are not moving. Very good. So the overall aim of the registry is to generate robust data, especially so on treatment options for women in the first trimester infected with malaria, to inform specifically policymakers as well as regulators, healthcare providers, and patients. At the time when MEMBA study was designed, when it was starting, quinine was the standard of care at the time. This is before AL was approved, so quinine was a comparator at that particular time. And we're also interested in ACTs, especially the newer ACTs, where we do not have sufficient evidence on safety in first trimester, specifically the hydroxystrobin, piperaquine, and pyronidine test unit. In the next slide, we'll take us through the methodological considerations. The time when designing the MEMBA registry, there are 5 things we needed to consider. The first is antimalarial exposure ascertainment. So what happens in routine practice is malaria drugs will be prescribed. They could be bought in a local shop or a local pharmacy. Some of them are prescription only and some of them are not. And when you compare this with other diseases such as HIV and TB, which are well documented, given in routine settings, strictly under prescriptions, and the drugs are better controlled, it's harder to track where antimalarials are prescribed, to whom, at what time, and by whom. The second thing about antimalarial exposure is the treatment duration is quite short, and in some malaria endemic areas, patients would have multiple episodes of malaria. It will occur multiple times a year, and therefore would have a recall problem. The second component we needed to consider was the gestational age assessment. In routine settings, we would rely on the LMP as well as the fundal height, so the last menstrual period. And sometimes women will not remember their LMP correctly, and therefore our gestational age assessments would be inaccurate. Then why would we need an accurate gestational age estimate? We would need to know when the woman was exposed to an antimalarial. We need to know the exact trimester that it occurred. And the only way to get a good estimate is to use a gold standard such as ultrasound. So in our sites, we did introduce ultrasound for gestational age assessment. And the third is the outcomes assessment. The pregnancy outcomes that we were interested in were things like congenital anomalies as well as fetal loss. And then when I look at congenital anomalies in routine settings, these are not usually systematically screened in routine settings, and some of them would require extra training to be able to identify and classify correctly. And the second component we think about in pregnancy loss is when women do report miscarriages, but we report as fetal loss in very early pregnancy, it would be hard to know if it was an induced abortion, or it was a spontaneous abortion, which is what we call a miscarriage, especially in settings where abortion is illegal. The fourth component we needed to consider was the sample size. If you look at the outcomes we were interested in, they're fairly rare, congenital anomalies and fetal loss, specifically miscarriages. Therefore, we need a very large sample size to be able to achieve adequate statistical power. And if you look at the example of artemisinin, especially the AL, it took us 22 years to achieve enough statistical power to determine if AL was safe to use in pregnancy. So this large sample size would need multiple sites and it would be to run over multiple years. And the last bit is bias and confounding. Unlike trials, observational studies, which is what we would have, what we would set up, is vulnerable to bias and confounding. When you look at malaria in itself as a disease, it's a risk factor for adverse birth outcomes. Then how do we tease out the cause of the adverse birth outcome? What came first, the drug or the disease? And we need an active comparator, especially women who are treated with a safe drug, e.g. AL, and previously that was quinine. So the next slide tells us, take us through how we designed member registry. So we designed it as a multi-center prospective observational studies with the 5 considerations I described. And it was going to run for about 4 years, from 2020 to 2024. We did it in 2 sites, malaria endemic countries of Kenya and Burkina Faso. And we targeted women at reproductive age before they got pregnant, 15 to 49, as well as identified pregnant women very early, either in their households or at the facility. The next slide. So data collection occurred and across multiple platforms. But the first thing we needed to do was standardize the data elements. So for instance, how we coded drugs needed to appear exactly the same way in all the multiple data platforms, which I'll tell you about. We needed to standardize procedures, such as early recruitment would need to be based on gestational age ultrasound assessments, estimation. We need to standardize, for instance, how we measure and determine pregnancy outcomes, such as congenital anomalies, and how we report them. E.g., we report them on the birth defects app. We make sure that anthropometry is the same across the sites and the training is well done. On the multiple data platforms, we really had 2 sources of data. So there's a primary data, which is the drug histories that patients gave us when they took the drugs, anthropometry, how we measured the babies, and how we screened the congenital anomalies. And the secondary data, we drew that from the Ministry of Health registers, which I'm calling MOH registers. At the time of the study design, MOH registers used what I would call analog methods. And we worked with a brilliant team of software engineers who designed this platform called ScanForm. And ScanForm allows us to collect data on what I like to call smart paper. We write on a paper, and using optical character recognition, we take a picture, it reads the data, and the AI inbuilt artificial intelligence reads the data, converts it into digital data within 60 seconds, and then translates that in analytics, which you then see as summary statistics as well as visual analytics. And the visual analytics have been very important in helping us track near real-time antimalarial exposure in pregnancy outcomes. For the drug exposure, we collected this data prospectively so that we could counter recall bias, and we used multiple sources to confirm the information. We looked at the data that was collected in the MOH registers, looking at the prescriptions that were given. Then we followed up the women either at home or in the facility with an exit interview to just confirm the type of ACTs that they were given. We introduced ultrasound into the study, trained clinicians to do ultrasound on the study site so that you could accurately determine gestational age. At newborn assessment or at delivery, we introduced digital skills to the health facilities with training in anthropometry, as well as training on congenital anomalies and reporting. The next slide will take us through a journey that when women are recruited, the first point of contact would either be a household, and that's the point where recruitment would begin. Recruitment involves informed consent, and it could occur either during household registration. So the counties where we work would have an annual household registration that is led by community health volunteers. This is a point where they would identify all the members in their villages, including women of reproductive age between the ages of 15 to 49. During the household rounds, we'd also identify pregnant women and would offer pregnancy tests. And that would be the first point of pregnancy confirmation. And in the earlier part of the study where pregnancy tests were not available, where a woman reported missed LMP, a missed period would then be referred for pregnancy testing at the health facility. At that particular point where women are recruited in the household, this is recorded in something called an MOH 513, which is a household registration tool. And we extract a combination of codes from the MOH 513. So it covers things like the community health unit code, the village code, down to the village, up to the household level, and the order in which the woman is named or is coded in the household. And that generates a unique ID. Some women would be contacted first in the health facility, which is they would come to the OPD for a sick visit. They'd be captured in something called an MOH204B, which is the outpatient register. And at that point, a data clerk or a facility clerk would then consent them and trace back their household to a CHB who would then register them or they issue the unique ID. So once a pregnancy is identified, the woman is referred to start antenatal clinic. And the first procedure would be an ultrasound to determine the gestational ages, and especially where they're within the gestational, where the ultrasound detection or the ultrasound would be useful. So at 28 weeks of pregnancy and birth. At that first NC contact, we then ask about her drug history. Her drug history as far back as she could remember since the start of her pregnancy. And repeat the same questions about drug histories and exposures to drug in every scheduled and every sick visit. And the data would be captured in two different platforms. The nurses would record their data in something called an MOH405, which is the NC register, and the drug history and patient history data would be captured by a clerk in Red Cup, and that should be our primary data. At delivery, which also covers any pregnancy losses, but maybe the best thing to call this is end of pregnancy. We'd also ask the same questions about drug history, but the point where the baby is born, we then do an anthropometry, we do saturation measurements, oxygen saturation measurements, and screen for congenital anomalies. And for those who had pregnancy losses, so either miscarriage or stillbirth, this would also be recorded in the different platforms, both the MOH, the pregnancy outcome forms, as well as Red Cup. 6 weeks later, we then follow up the mom and baby. Specifically, we're interested in the baby, again, repeating the same measurements, again, screening for congenital anomalies. And in some cases, very early when the baby is quite young, some congenital anomalies could be missed and will become more visible at clinical examination at week 6. And week 6 coincides with the time when the baby is coming for the routine immunization. It also repeats the SP2 measurements. So why these oxygen saturation measurements are important, we use it as a mechanism to screen for congenital heart defects. Some of them would have been associated with ACTs. For a subcohort of children, we follow them up at 6 to 12 months. These were children first who are immediately exposed to ACTs, and we match them to controls who are non-exposed, and we did neurodevelopment assessment. We continue screening for congenital heart defects, even as late as 6 to 12 months. Next slide. So these were the primary endpoint of interest. So we took a composite endpoint of miscarriages, stillbirth, and major congenital anomalies. I'd like you to focus on the color, which represents the primary composite endpoints. At first trimester, between first and second trimester, we collect data on miscarriages. From second trimester onwards and stillbirths. So babies born, so stillbirths were those that occurred after 28 weeks of gestation. And at 28 days at birth and at 6 weeks, we then assess for any major congenital anomalies. So looking for any structural abnormality. We do the same thing at 6 months and at 12 months. So taking into the gray parts, we also had some secondary outcomes of interest. We tracked maternal death, low birth weight and small for gestational age between second and third trimester, and at birth, neonatal death. And at between day 28 to month 12, which are neurodevelopment delays, major and minor congenital anomalies. So all the data that we collected in the next slide. So the overall data management is supported by one in data collected from specific sites, then cleaned and then they're linked to a country-specific database. They're anonymized from the country database and then they are shared with the central registry, which is held at one. Then it's converted to a standard format for data analysis. And then the anonymized data from the central database is then shared with the WHO TDR International Pregnancy Registry. So for the next 4 slides, I'll take you through the Kenyan updates. So this will be a Kenya-specific update, and we'll not include the Burkina site here. So in Kenya, we opened the site in Homa Bay County, which is the western part of Kenya. It was a malaria endemic area, and we opened 3 different sites. Why we chose this site was because at the time, MMV had sponsored a study with another institution for rotational multiple first-line therapy in that particular population. And the ACTs in circulation were DP, diratemicin, piperacin, Paramax, AZAC, attesunet, amodiaquid, and AL. And the rotations varied. So for instance, DP and AZAC were meant to be rotated for 6 months and switched to AL. And Paramax was sitting for 12 months before the site switched to AL. The island sites, the ones you're seeing that look like are in the middle of the Lake Victoria, were the ones that rotated Paramax, and the island sites are the ones that rotated the hydrotomycin, piperacin, and AZAC. In total, we covered 52 facilities and 428 villages. And it's the CHVs, or the community health volunteers, who helped with the initial household registration and helping us to create a unique ID. Why this unique ID was important is because it's the ID that we use to link data across multiple platforms. So for instance, data that is extracted from an MOH 513, as you can see, the CHV filling in that book. She'll then take a picture at the end of completing the book. This data is then generated and helps, and a search database is created, as you can see on the left. And the search database contains the codes that helps a data clerk sitting in a health facility to be able to search the particular mother that she wants to interview about drug exposure. She'll ask questions around where the sub-county the mom comes from, the village, the household name, the community unit, and she'll be able to narrow down that this particular woman, and those are her initials and the household that she comes from. Every month, the CHVs, the community health volunteers, would check on mothers that identify new pregnancies, do pregnancy tests in the community and refer for ultrasound. They'd also identify non-study site antimalarial exposures. As I mentioned before, you can buy antimalarials in your local shop. Some of them are registered pharmacies, some of them are non-registered pharmacies. And every quarter, they will do a sweeping round, which we ended up calling an RRI, where CHVs would then repeat pregnancy tests every quarter, household to household, and refer those who test positive for ultrasound. The next slide is not the results of the study, but the MNE. So this is the monitoring and evaluation that tells us where we are as a study and where we hoped to be in the couple of months. We started with the initial target of about 42,000 women of reproductive age, and so far we've reached about 45,000. We hoped specifically that we would be able to identify at least 304 first trimester exposures, and so far we've achieved 76% of our target. But what's interesting is that the majority of these exposures are AL. So maybe not so interesting because this was the standard of care and was in circulation longer than the newer ACTs that were distributed. So up to 66% of women received AL. The other antimalarial that is of interest that is new was Paramax. About 7% of women had been exposed, and quinine was about 22% of women. With a new change in guidelines, this might be good for us because AL would then be the comparator and be able to gain statistical efficiency with a 1-to-4 treatment to control exposure ratio. We've had a few challenges and opportunities in the next slide. We work very closely with community health volunteers And that means they are quite valuable, not only to us, they're also valuable to multiple programs, and their time is split across multiple studies. The opportunity here is that during peak seasons, we train CHBs to multitask and incentivize them to test women at home and refer them to start clinic. We also have programs that offer early pregnancy identification, and when they do that in the health facility, the women were started on what was then the standard of care to screening at the time, and therefore we missed opportunities indirectly for accidental exposure to ACTs as women were weeded out early. We have multiple data platforms in Homa Bay County. This is one of the counties that's quite open to new technology. And the picture on the left, you will see a data clerk would fill in data, one on an MOH register that is compromised on a tablet for the Elephant OS system, another parallel system, and in her hand was a Kenya EMR system, a parallel system. So it's still one healthcare provider filling in data across multiple platforms. The opportunity we see here is opportunities for data linkage and also validating our data, which is what a PhD student is looking at. Homa Bay County was sprayed at the time when MIMBA was rolling out, so indoor residual spraying. So we did see a drop in malaria incidence. However, this particular program is ending in March. Due to multiple challenges with the supply chain for the MUT study, the multiple first-line antimalarial exposure, at the time it was because the drugs were distributed by the Ministry of Health. In this particular case, some of the ACTs were delayed to arrive in the site. So for instance, DP and AZAC had a short exposure of less than 6 months. And so we requested the funder if we could continue tracking Paramax and expand it to additional island to be able to do this. And also we are extending recruitment to be able to do this. I want to thank everybody. The next slides and acknowledgements. It's a very large team that makes this possible. In the last slide, and each institution is led by a different person. And because this is a week that we're celebrating women in science, and our chief investigator is Stephanie Delacroix, who has been providing excellent support. Thank you, everybody.
Thank you, Dr. Ellen, for presenting this great study to this webinar, and we can't wait to see the results. So let us now hear from a country perspective. As you know, though the new recommendation of WHO on the use of ACTs during pregnancy was released only in November 2022, some countries such as Tanzania have been proactive and took the lead to conduct this intervention. So our presenter today is from Tanzania and is Dr. Abdallah Lusasi. Dr. Abdallah Lusasi received the MBBS and Masters in Public Health from International Medical and Technological Universities and a Masters in Project Management from the Open University of Tanzania. Dr. Lusasi performed his medical internship at Muhimbili National Hospital. He worked at the NMCP as the Malaria in Pregnancy Coordinator for almost 7 years. In 2018, Dr. Lusasi was promoted to be the team lead for malaria case management, where he brought abundant experience and lessons learned on malaria control. He led the introduction of community case management intervention in Tanzania and the review of the diagnostic, treatment, and preventive therapies guidelines of 2020, which included the use of ACTs in the first trimester. Thanks, Dr. Lusasi, to accept to share the Tanzania experience with us. The floor is yours. Thank you. Dr. Lusasi, yes.
Yeah, thank you so much, Noella. I'm Dr. Lusasi from National Malaria Control Program, Tanzania. First of all, I would like to acknowledge the team who supported me to reach here, the PMY Tanzania, the Swiss CTPH, and the entire team of NMCP team who supported it to prepare this presentation and to make me a presenter today. So I will take you through the treatment of malaria in the first trimester of pregnancy in Tanzania. Can we go ahead? This is the outline of my presentation. When did Tanzania change their policy? What has changed? The data of pregnant women who tested positive during their first visit to ANC. The main challenge in implementing this new policy, the lesson learned from implementation in Tanzania. Next. We changed our national guideline in 2020 before we have the guideline of 2014. And then the dissemination of this guideline, which included these changes in the treatment of first trimester in the first in the pregnant women, we disseminated this guideline countrywide up to the level of administrative region and their respective district health teams. Thank you. Can we go? What has changed in malaria pregnancy first trimester malaria treatment? So if you see on the upper top, the top column, we have the recommended treatment, the old one of 2014, and then the updated one is of 2020. So in uncomplicated malaria first trimester, before on 2024, we used the quinine tablets, giving pregnant women for 7 days. If you take 7 days times 3, almost 63 tablets, it was a large amount. But we recommended that from the second trimester, we recommended to use the ALU. Again, on the treatment of severe malaria or trimester, we have been using the injection of quinine in 2014, but we changed in 2020, we use the injection tosinate. Can we go ahead? Data on treatment of pregnant women. The clinical categories of uncomplicated and severe malaria pregnancy, data is not captured from a facility through the routine HMOS or HS2. This is the system where we are taking we are capturing, we are collecting the information, the data from the facility. So this information is not captured. The PLOX national indicator for malaria pregnancy burden in pregnant women who tested positive during their first visit to ANC. This is captured in HMOS, DHS2, in all regions, almost 26 regions. There is no categorization of trimester in the standard output, but it is possible to develop a second analysis platform. All pregnant women who tested positive, regardless of their trimester, receive ALO. This is a very specific, it's ALO, in line with the treatment policy. The anemia in pregnancy and its management is as not well captured in routine health facility generated data, but it needs special attention. All the above factors needed to be monitored according to the malaria transmission risk framework. Yes. This is it's a report, it's a data of from 2016 to 2020, almost 7 years. If you see on 2016, the testing rate was 75%, but the positivity rate was 7%. And then if you come to 2020, the testing rate was 98%. It has been increasing, and the positivity rate is 6%. This is the report of 2022. If you see the right map, this is a Tanzania map. It shows the positivity rate across the country. And if you see again this northern part and the central corridor of Tanzania, and if you come down here, the southwest part of the Tanzania, the transmission is less than 1. So again, in under 5 age and the pregnant women also, the transmission is fairly low. Next thing. The main challenge in implementing new policy. The routine monitoring of adherence to new guidelines is impossible within current HMS reporting tool. There are additional information to be collected with the ad hoc tool during the routine support supervision. The early pregnancy not recognized by clinician or not reported by patient during clinical assessment. This doesn't affect the treatment, but it might underestimate the number of pregnant women in the first trimester attending a facility due to malaria. The healthcare worker orientation on new policy not systematically done at a facility level due to high cost for traditional training process. Innovative low-cost training modalities to be introduced. This is e-learning or distance learning, or to use the social media. Actually, we're using the SBCA in our country. The adverse drug reaction not well reported within the current operational setting. Here now is strengthening the passive and introducing the active pharmacological vigilance. Next thing. Next thing. The lesson learned from implementation. Specific implementation of malaria policy in special group needed to have an active monitoring system. The pregnancy as well as that biological vulnerable factor needed to be included into malaria vulnerable framework. Other pregnancy risk factor needed to be monitored as well. HB level, for instance, preventive therapy, occupational exposure, anemia management, and access to health care. Socioeconomic background of a pregnant women should be considered. The epidemiological risk needed to be included in tailoring effective malaria in pregnancy control package. What to do in extremely low as well as extremely high malaria transmission setting. Next thing. Thank you so much for listening. Next thing.
Thank you so much, Dr. Lusasi. That was really fantastic. So before we open for the question and answer, I just very briefly wanted to mention both to note that the recording from this presentation will be shared after this will be shared out, and also that we have developed a brief to help guide NMCPs and partners in the implementation of this new policy guidance, and that will be sent out in English, French, and Portuguese shortly after the webinar as well. So I want to thank all of our presenters. This has been really a fantastic session so far, and we'll open with the first question, and I think we can ask for, I don't know if Webby is able to speak, but if so, we can allow you to actually ask the question that you've put into the chat. Amanda, are we able to unmute Webby? Okay, if not, I will go ahead and ask. So it says, great to see the new artemether-lumefantrine recommendation in the first trimester of pregnancy. However, Piramax artesunate pyranerdine is not yet recommended. Is there a deliberate strategy to deal with the risk of providers prescribing both ACTs to women in the first trimester? So maybe, I don't know, Stephanie or Helen, if you want to comment on that. Perhaps Helen, you have the most experience of what has been happening and can speak a little more to the experience so far with artesunate pyranerdine.
Thank you, Julie. I will answer this question with Stephanie. So for the first component, in practice, when providers don't know if the woman is pregnant, especially in very early pregnancy in the first trimester, and they haven't done a pregnancy test or it's not clear yet, they would prescribe during the rotational MFT study, whichever ACT was in circulation. In terms of a deliberate strategy, it would be recommended to screen women for pregnancy first. Any woman appearing in an outpatient department between the ages of 15 to 49, not on contraception, or is quite sure that they wouldn't be pregnant. And if they are positive, pregnancy positive in the first trimester, then you prescribe AL instead of pyrrolidine at test unit. However, the member study, which is going on in Homa Bay, that's tracking accidental exposure, will be able to give us data in some time in the near or distant future about the safety of PA. I welcome Stephanie to also contribute.
Thank you. I think, Helen, you've answered it very well. And just to highlight that, indeed, in a lot of the studies, we see that most women in early pregnancies are treated with whatever first-line antimalarial treatment is being used, because there's no systematic screening of pregnancy. So there's a lot of inadvertent exposure. And I think this is where we really, from the previous presentation, to strengthen pharmacovigilance systems so that in countries where they are rolling out Pyramax as first line, there is some system to gather that evidence as quickly as possible so that we can have information on this accidental exposure, provide some reassurance, and hopefully we can find innovative way to really fast track generation of evidence on this new ACT, so it doesn't take 22 years or more to get the relevant information. But thanks. I hope we answer his Webby's question.
Thanks so much. I think Dr. Lasasi wanted to add to the answer as well. So go ahead, Dr. Lasasi.
Okay, thank you so much. I received one question from our stakeholders saying the country experience with the AL implementation. What is being done to prepare NMCP for implementation of this policy? This was my question, but I would like to say, as a country, we prepared the policy, we updated our policy. This was a national strategy plan of 2021-2025. Then we adapted this to treatment guideline, which including preventive therapy policy of 2020. Then what we do again is drug quantification and the other logistic relating to the pregnant women treatment on severe malaria and non-severe malaria. We do orientation to the supervisor, these are HMT and the CHMT. And then we make a follow-up with the MSCDQI checklist to the facility level, which assess the quality of service through observation to a health provider. Then we get a chance of mentor and coaching. Thank you so much.
Thank you so much, Dr. Lasasi. I see that there are a number of hands, so we will go to, and I apologize if I pronounce the names poorly, to Bala Giba. Can I ask for you to unmute and go ahead and ask your question?
We can't hear you, Julie.
Yes, I just noted. So Bala, go ahead. You should be unmuted and able to speak to ask your question. Okay. Maybe it seems that there is some issue with your microphone. So maybe you can type it into the Q&A and we can move on to Gautier Messia Kahunu. Go ahead. Amanda, can you unmute? Oh.
Vous m'entendez?
Yes, please go ahead. French is
Hello?
okay. Yes, go ahead.
Yeah, I will speak in French because I'm from a French-speaking country.
Go ahead.
OK. J'ai suivi avec attention les recommandations de l'AL. Je vais dire ceci, dans certains pays, nous avons déjà des soucis avec l'efficacité thérapeutique de AL qui commence à montrer une tendance à la baisse. Et dans des grands pays comme le nôtre, il y a des coins où, en fait, maintenant, on est en train de réfléchir sur l'alternative à l'AL. Maintenant, nous avions eu les premiers problèmes avec l'utilisation de sulfadoxine pyrimétamine en traitement préventif chez la femme enceinte, parce que beaucoup de prestataires de soins disaient « Pourquoi vous voulez qu'un médicament qui n'est plus efficace, en tout cas, il y a des taux d'échec très élevés, ne marche pas chez tout le monde et que ça peut marcher seulement pour protéger la femme enceinte. » Mais il y a un débat entre les pédiatres et les gynécologues là-dessus. En tout cas, l'une des solutions proposées, c'était de multiplier le nombre de prises par rapport au nombre de CPN. Maintenant, pour l'AL, est-ce que nous ne risquons pas de nous retrouver avec cette situation où nous utilisons un médicament qui, dans certains coins, a perdu son efficacité, en tout cas dans de larges proportions, pour pouvoir prendre en charge un paludisme que nous considérons déjà comme compliqué chez la femme enceinte? Voilà un peu la première question que j'ai à poser.
Julie, do you want me to translate that?
Yes,
So
please.
I'll translate for the Anglophone. So I think Mr. Gauthier talked about the fact that he followed carefully the presentation, which were very important. So he's raising a concern about the efficacy of AL, which is decreasing in some countries, especially in his country, in some part of his country, probably DRC. So I'm saying that with SP, providers are already concerned on the efficacy of preventing malaria among pregnant women, because they are saying that it's a drug which is not working properly. It's no more efficacious to treat malaria. How does it work on pregnant women? So he's wondering if we are not risking to be in the same problem for AL. What are we going to do? How can we avoid to go to the same problem with SP? Thank you. Who can respond to this? To
Andrea?
who can we address? Andrea, probably.
Please.
Yes, let me have a first go. Can I do in English or you prefer in French? English.
No, please in English, the
In English.
translators will translate.
Yes. So there is a lot of studies with the use of SP for IPTP in pregnancy showing the efficacy, and even some showing compared to DHAP paraquine is even better in reducing low birth weight. So the amount of evidence, because again, there is an effect on the placental malaria, probably unknown effects on other illness, which could affect like bacterial infections, which are also linked to the sulfonamide component. And then the whole parasite load density, which we have in a placental infection, is very different from an acute malaria, uncomplicated malaria. There are many factors which can explain why SP works for preventing malaria in pregnancy and effects on the newborn compared to its limited use. Actually, it's not effective to treat uncomplicated malaria. So that's, I think, we are in a different, completely set of consideration. And again, there is a lot of studies which shows this, which prove this with data. Now, on lumefantrine loss of efficacy, the data are not fully consistent. Also, because many studies have used a different approach to look at failures. They looked at a probabilistic approach, which is not fully aligned with, again, what WHO recommends in terms of doing therapeutic efficacy studies. So we don't have yet a strong evidence or let's say clear evidence that lumefantrine, so artemether, lumefantrine is failing in Africa. So while, of course, there are some places like in Cambodia where this drug is no longer effective. So at least for Africa, so far, we may say we need more research. Now, on the new recommendations, having now AL as the first line, the recommended treatment, this may also open not only pharmacovigilance, pregnancy registries, but also some good research in the first trimester comparing this regimen, the 6 dose twice a day for 3 days AL with other ACTs, which are maybe more simple to use, and then doing a one-to-one comparison, we can look at especially efficacy. It's very difficult to really go into the other complications, the congenital malformation, because those are very rare events. But when we have a lot of data, like in case of quinine, we have a massive amount of data in the quinine-treated group compared to the AL group. So this is, again, you can extract this in the treatment guidelines. There are the evidence and the summary for this, and also in the publication that Stephanie mentioned in their good work, there is an excellent table which looks at the frequency of specific congenital malformations in the two groups. So always good to have comparative data because malformations will occur spontaneously, and it's important to know what is the other group also showing. So maybe over. Thank you.
Thank you. That was an excellent response. So I think if we could ask Miriam Uzoanya to be unmuted and ask her question. I believe you can speak now, Miriam. Miriam, go ahead and unmute yourself and ask.
Yes, Julie.
Okay. So while we're waiting for Miriam, maybe Dr. Lusasi, there's a question for you in the Q&A. How did you get the acceptability for AL as a BCC approach? Maybe you can answer. Thank you.
Yeah, thank you so much. I've seen it. According to the experience of Tanzania, it's an endemic country where 60% of pregnancies occur. And it was the chances of pregnant women to be exposed to ACT is high. And we had no incidents of congenital malformation, stillbirth, or miscarriage. So the time we pregnant women, before starting use the ACT, have been using the quinine, as I've said before, but most of them has not been completing the dose because the quinine was almost 62 tablets, a lot. And as you know that during the first trimester, there are so many disturbances to these pregnant women. So it has been very easier now to take the AL. So the BCC was very easy, actually. People understood very well, and then they're using now. Thank you so much.
Thank you so much, Dr. Lusasi. So I'm noting that we're at 9:30. I do want to just note what are some comments in the chat that regarding the availability of counterfeit artemether lumefantrine being one of the factors responsible for poor efficacy, highlighting the need for additional monitoring for counterfeit drugs, as well as from Dr. Tinto, the rate of the high rate of new infections, meaning that AL, which has a relatively short half-life compared to some of the other options, allows for reinfections to occur relatively quickly. So these really highlight the need for us to speed up research on drugs that can be used for pregnant women and women of reproductive age, because the current available options are insufficient to provide optimal protection. So just highlighting the need for these additional studies and the need for funding for data gathering efforts such as pregnancy registries and R&D that is inclusive of pregnant individuals. And given that we are a little bit over, and I'm sure everyone has other calls to get to, I'd like to thank again very much all of our presenters for the fantastic presentations today, and really appreciate all of those who were able to join us live for the webinar. We will be sending out the recording of the webinar so that you can re-reference it later. And I recognize there were some questions that were sent in earlier that we did not manage to get to, and we will try and answer those by email as well. So thank you all very, very much. Maybe I can ask all the presenters to turn on their cameras quickly just so that we can have a final round of applause. So thank you.
Thank you, everyone.
Thank you all. Have a great rest of your day.
Thank you, everybody.